Well, we will now begin the portion of the business meeting to take public comment. This purpose is to allow members of the public to directly address the commission on issues of public concern. Please refrain from providing comments on pending or open investigations or disciplinary cases. We will not be answering questions or responding. Staff will be available after the meeting to answer your questions. Please understand that although the time period for comment during the business meeting is limited, the public can attend and provide comment at commission committee meetings. The public can also contact staff during normal business hours. We also welcome written comments. Each commenter will have 2 minutes to speak. When you comment, please state your name and who you represent. Would anyone like to comment at this time?
Angela Ross, go ahead. Hold on. Well, it looks like she is self-muted.
Is there a way to unmute her microphone other than?
It is not. Hold on, let me do this real quick. So hopefully she's able to speak now.
Yes, I am here.
Good.
Thank you. I was ready to go, but I didn't have controls. Thank you so much, Dr. Domino, for allowing me an opportunity to speak. I'm Dr. Angela Ross. I'm a licensed naturopathic physician here in Washington. I'm also the executive director of the Washington Association of Naturopathic Physicians. I apologize for background noise. I'm actually sitting in a hotel lobby hosting an event today for naturopathic physicians. But I wanted to take just a brief minute to introduce myself and let you know that I'm here. I'm happy to be a resource on agenda item 5.1, which relates to the bill we have brought forward, aiming to increase patient access to high quality, competent care, reduce costs for patients, the state and private insurers, and ensure the safety of patients and the public when they seek care from well-trained naturopathic physicians. I'm very grateful to Mr. Keranen and Ms. Boyd for adding some additional information for your consideration about our current Sunrise Review. And of course, to every member of this commission who spent some time with that material. I know it was a lot of information and a lot of reading. I also want to acknowledge that we are aware of the position of the Washington State Medical Association on this effort. We're here today to really listen, to learn, and to engage in whatever dialogue your members are open to. Obviously, we would enthusiastically welcome your support and collaboration on this effort, but we acknowledge that may be a significant ask. So in that case, I would ask that your commission consider neutrality as a way to acknowledge that there is a diversity of opinion on this matter within the profession your commission regulates. Either way, we are incredibly grateful for your time and attention to this important topic, and we look very forward to hearing the discussion this morning. Thank you so much.
Thank you so much for your comments. Are there any other people on the phone who wish to comment? Any other hands, please raise your hand.
There are no other hands raised.
Okay, well, this concludes the public portion, the public comment portion of the meeting. I want to thank you for your comments. And again, you may provide written comments at any time. All right, the next portion of the meeting is the chair report. And I don't have a very long chair report other than saying that we had, I think the majority of the commissioners had gone to the retreat, and I thought it was excellent. I thought staff arranged things very well. and we had really good discussions and a lot of ideas for modifications in the strategic plan for the next several years for improving the function of the commission, both in terms of protecting the public and in our evaluations and the way we work. So anyway, I thought it went out very well, and that I think was a really great process to go through. And again, really thank the staff for pulling this together. All right. The next thing deals with the consent agenda. And there are two items. Amelia, do we need to do them with these minutes separately, or can we do them both together?
No, the consent agenda you can do all as one vote.
All as one vote. Great. So we had two elements of the consent agenda. It was the minutes of the July 14th, 2023 business meeting, and the agenda for our approval for our meeting today. So we'll deal with these together. Please raise your hand if you approve these two items on the consent agenda. And I certainly do. Is anyone opposed to approving these items? Please raise your hand. Arlene, are you raising it in favor of it or opposing it?
No, I've lost some of the controls on my thing. So I raised it in favor, and then when it was still up, I tried to take it back down and it put another hand up. So
Oh, okay.
I'm in favor.
Okay. All right. So it looks like everyone has approved this. So our next item is dealing with new business, and this is Senate Bill 5411, increasing the scope of practice of naturopathic physicians. Kyle, you will present this bill, it's my understanding, for discussion.
Yes, thanks, Dr. Domino. This is, as Dr. Domino just mentioned, this is for discussion. Micah and I had reviewed this, and there is a slight bit of history to it, and so we thought it would be appropriate to bring it back to the full commission for comment and a potential vote. There are multiple pieces of information that were included in your packet, not the least of which, of course, is the actual bill text itself. I think the primary thing I'd like to draw your attention to at the outset is with regard to increasing the scope of practice for naturopathic physicians to be able to schedule, prescribe substances on controlled substances schedules 2 through 5. As some of the history around scope of practice for naturopaths indicates, and I think the Sunrise application, the request kind of outlines it quite well. They do have limited ability currently to prescribe controlled substances. Generally, it's I'll be as concise as possible, but it's testosterone and codeine and a handful of others. This is not the reason that we're bringing this to you is because this is not the first time that this particular issue has been in front of the commission. At the very end of the packet on pages 67 and 68, I included a comment from 2014 from then Chair Dr. Brantner. Dr. Brantner was pretty direct in his statement to the Sunrise Review Committee. I'm not positive that if we choose to take action, I'm not positive I would phrase it in quite the same way. But we did want to bring it to the commission as a whole for discussion. If you have questions, Micah has a fair amount of history behind this. I dare say that I have a pretty good grasp of how controlled substances work, both in terms of prescribing and the interface with federal law, et cetera. So we're bringing this to you because the commission has a couple options. The first option is to do nothing. The second option would really to be to provide comment to the Sunrise Review Committee. And if you all choose to do that, because of the timing that's involved, it would be something that if we could get kind of a general consensus from you about what you would like to say, I think it's probably going to be most effective for staff to kind of facilitate the actual written comment. So with that, Micah, do you have anything you want to add here?
Yes. Good morning, Commissioners. So the main thing that I would add is just some history with respect to opioid prescribing in this state. If you're not familiar, we've got a kind of inglorious history as prescribing professionals and regulating that, starting in the Wayback Machine of I would say the seminal event was the Pay at Clinic issue in 2010, which generated the bill that required us to create opioid prescribing rules for chronic pain. And so that we went along for a while, and we had the Seattle Pain Center issues in 2016, which that along with an increase in acute prescribing and not a lot of controls generally, resulted in a 2017 bill that required us to create opioid prescribing rules for acute, subacute, and perioperative pain, as well as update the chronic pain rules. And so when you're considering this, looking at the history, there's a regulatory structure that is in existence for the prescribing professions currently. It's rules, it's the PMP, you've got experienced staff, someone like Kyle who's got basically encyclopedic knowledge about controlled and legend drugs and how that interacts on the state and federal level. And so there's a lack of this basically. And so what I'm bringing to you is the regulatory inexperience, so to speak, with respect to regulating prescribing in this profession. And as Kyle mentioned, the straight up opposition that is mentioned in the Chair Brantner letter, I think it's safer to lean more towards, we have concerns in these areas and we want to highlight those things. And so that's really the substance of it. There's a whole narrative about the differences in training, especially when we're talking about the differences in patient contact hours between, say, even between a family medicine doc and an anesthesiologist pain management. You're going from 10 to 12,000 patient contact hours for the family medicine doctor, where anesthesiology and pain management is up to 16,000. This is not a simple thing to regulate. It's not a simple thing to manage. And so we would like to be able to highlight some of the differences there and raise concerns and ask, how are we addressing those within the Sunrise review process?
Thank you, Micah. Do we have comments from some of the commissioners? I can't see everyone, so I may have Amelia make some comment, figure it out who's raising their hand. Mr. Rogers, I do see your hand raised.
May I defer to Dr. Murphy, who I see is raising her hand? I don't want to speak before a clinician.
Dr. Murphy, I didn't see your hand. It's under my mute button. Yeah.
Thank you, Scott. Given the opiate crisis, given the CME and patient contacts that clinicians who are MDs and PAs have in this state, the most recent of which to renew your license and your DEA, there's 8 hours of continuing education on opiate prescribing, recognizing and averting opiate substance abuse, et cetera, et cetera. I see nothing that would prepare naturopathic physicians for this prescription. And I think neutrality would be a mistake. I think we need to oppose this bill.
Mr. Rogers.
That was kind of exactly what I was going to comment. Just looking at interactions between opioids and benzos alone is very complex physiology and requires quite a bit of pharmacological knowledge. And and in addition to interactions with other things and looking at other features, I as a public member, non-clinician, I think it's way too complicated to have people prescribe these agents who do not have the training and education to monitor for everything that can go wrong and often does.
Ms. Blake, I see your hand raised.
Thanks, Dr. Domino. I would agree. Yes, I think that naturopathic medicine and the drugs that they're requesting are a bit of a dichotomy. I don't see how a naturopath would be wanting to prescribe medications that they typically feel are not in their field or what they feel that people should be on when they're treating them. So I don't see the need or the tie between those two. And I think myself that it's a little bit dangerous to start bleeding those into a naturopathic provider's scope.
Ms. Boyd, you have your hand raised.
So Dr. Curry is on the phone, and I believe she has a comment.
Okay, Dr. Curry.
Can you hear me?
Yes, we can.
Oh, good. I'm so sorry about the background noise. I have one quick sort of, I don't know, technical question about this bill. A lot of it also revolves around signing forms for disability, evaluations for, mental illness, ADHD, even assisting with abortions. Are we discussing that part of it, or are we only concerned about the opiate prescribing? Because I have a lot of concerns about some of the other pieces that I read. Thanks.
My understanding is if it's in the bill, we should discuss it if there are things that are of concern.
Okay, well, I just want to register that I have concerns about some of those other things in addition to some of the things that have already been said. Thanks.
Do you want to say more about it?
I am concerned about the lack of training for evaluating for things like autism spectrum disorder, ADHD, et cetera, and the medications used to treat these things. A lot of people get disability forms signed based on mental illness diagnoses. Also, the evaluation of physical illness type diagnoses that lead to disability forms being signed. I just don't know that I feel comfortable that naturopaths have enough training in those areas. And that could have a pretty big impact down the road in terms of how our state handles all those people, right? So that's a big part of primary care, treatment, evaluation, et cetera. And then the one little throwaway line about abortion, assisting in abortions or providing abortion care, gave me grave concern. We'll just leave it at that.
Thank you. Any other commissioners have any comments? Please raise your hand. Mr. Lopez.
Yes, good morning. While I realize that the primary care provider shortage across the country, not just in our state, is dramatic and appears to be growing exponentially predicted over the next 5 to 10 years. My concern, of course, is what kind of providers will be able to service the community that has such dramatic needs, particularly in the area of opioid prescribing. It appears that opioid prescribing seems to be increasing, not decreasing, and the complications and death rate, again, continues to increase, not decrease. So myself, after 40 years of prescribing controlled substances, I can tell you that over those years, I realized how little I know about opioid prescribing. And in fact, as Dr. Murphy has already stated, that the DEA has insisted that regardless of our experience and background, that we all need to go back to learning more about opioid prescribing despite our experience and our previous education. So to try to insert another profession who seems to not be well trained and educated in the nuances of opioid prescribing, I believe would not be in the best interest of our patients in this state.
Dr. Pullen, I see your hand raised.
Yeah, I'm concerned with the opioid crisis on the street. I'm concerned with the expanding the potential of opioids getting on the street without a person having extensive training and controls.
Dr. Chang, I see your hand raised.
Yeah, and I actually expressed the same concern about this. But on the other hand, this is not because it's that, in terms of that worry about their ability to prescribe. It's more like it's a lack of understanding of their profession. In my limited contact with the naturopath, I'm basically sometimes kind of questions their judgment as acting as a primary care because they diagnose things, and also will order kind of over prescribe things that which is not necessarily accepted by the allopathic medicine. And then in addition is that I'm looking at this is that, in terms of the requested opioid ability to prescribe opioid medication, my assumption is that they're thinking about prescribing natural, basically a natural opioid, a naturally derived opioid, such as kind of a tincture of opium, or CBD, or or a cannabis product, and that's their prescribed part of their precipice of requesting to add this. And that raised my concern is that we just don't have a lot of understanding, even within our professions, understanding about all those kind of effects in those natural product, and you're adding more of those to the opioid crisis, and that just doesn't sit well with me.
Are there any other commissioners who have their hand raised? Any other discussion? Ms. Boyd, do you see anyone else? No one, I don't see all the people if they're raising their hand. Mr. Matthews?
Just one point of clarification for what we're asking based off of the discussion. We're not asking for you to take a position on the bill itself. The ask is to authorize Kyle to author a letter to the Sunrise review process. So just so everyone is aware, the Sunrise review process kicks off when a legislator or other individual asks DOH to evaluate either a scope expansion or creation of a new profession. And so that's what's happened here. The bill is a template for what is being asked for, and the DOH is evaluating it. So this would be a comment on the Sunrise process itself, and not the commission taking a position on this particular bill.
So do we need to have a vote?
So Dr. Domino, this is Kyle. Yeah, it would be helpful if we had a vote that would allow us to comment on the Sunrise review process for this particular bill. With your support, I think Micah and I can, with some consultation from Heather, can write a letter that kind of echoes the concerns that you all have made here with regard to a couple different aspects of the bill. It was Heather's advice that we bring this to you and make sure that we have authorization from the commission as a whole to provide that comment. And it was also an opportunity for me to bring this in front of you so you're aware that it's going on in the background. And so a motion to authorize comment that expresses the concerns that you all have just listed out would be super helpful.
Mr. Lopez, I saw him first, and then
Yes,
Dr. Murphy.
Yes, thank you. I guess the question I had was, will we be able to see that letter once it's been composed, that we are certain that it expresses our conversation?
Thanks, Ed. I'm happy to, we have a little bit of time in order to kind of formulate that. I think it's going to be very difficult to bring it back to the commission as a whole and kind of get everybody's comments on, 21 plus members of the commission providing comment is always a little bit chaotic. And so another option would be to select a handful of you that would work with us to make sure that once we have a draft done, that it appropriately expresses your concerns. That would be fine, I think, in terms of a route forward. Heather, please feel free to speak up if you have any other suggestions.
Yeah, I agree that maybe if there were a couple of commissioners who were especially interested in this, maybe Mr. Lopez and someone else to help you review the letter once you've got it drafted to make sure it captures what you want it to capture.
Dr. Murphy, you were next.
Yeah, I move that we authorize Kyle and staff to draft a letter with Heather and Micah and others, and that it be brought back and we could do this by email to at least the executive committee. And if anybody else wants to weigh in on it, let us know. But that the executive committee would have a final view of it before it goes out and becomes official.
So before addressing that, Dr. D'Souza also was waiting in line to make a comment, but her hand is down.
Oh, yeah. Oh no, thank you. I simply wanted to point out that in order to practice primary care, controlled substance prescribing isn't a necessity. So during residency, for example, I practiced in a public health clinic and there were no controlled substances prescribed at that clinic, and I was able to do the job that I was asked to do. All the clinicians who worked there did. So just something I wanted to add.
Thank you. Now, do we have a second for Dr. Murphy's motion?
Second.
Okay, well, we take a vote. All in favor of the Murphy's proposal, please raise your hand.
Aye.
Yeah, or say aye. Anyone
Aye.
opposed? We'll wait. Any commissioners opposed to this? There's someone still has a hand raised under participants for being opposed. It's gone. Okay. Well, so Kyle, you have you guys will compose a letter, send it to the executive committee for review and modifications, and then submit it.
Thank you, everybody, for your attention. Much appreciated. I'm sorry for the last minute nature of kind of getting some of the material to you. We're under kind of a little bit of a tight timeline. But thank you for your attention to this.
Okay, now we'll move on to committee and work group reports. Are there any committees, there's a list on page of work groups who want to provide any update? I will leave the high reliability organization HERO work group after dealing with any other work groups. Anyone have any updates they want to say from a written, in a verbal manner? I don't. Mike Farrell?
Yes, thank you. Good morning, everybody. I want to present on behalf of the HERO work group a revised statement of understanding between the Commission and the Foundation for Healthcare Quality that describes how the two entities will work together to process cases of medical error that have been certified by the Foundation's Event Review Board. So since it's been 6 years since this SOU has been revised, I suspect most of you have never seen this document before. So I'm going to give a little bit of background, and then I'm going to go over one section of the document. So this is a project that began about 12 or 13 years ago. The Commission at that time was looking for a way to be more proactive in improving healthcare and reducing medical error. So we had a couple presentations at a retreat back then, one on just culture and one on communication resolution programs. So communication resolution programs, or CRPs, as most of you know, are a way to improve medical care. It involves an institution having when there's an unanticipated outcome, the provider tells the patient right away, and then an investigation is done to determine what happened, and then they identify systems issues that may have contributed to the outcome. This is all shared with the patient, and then systems changes are made to make sure it doesn't happen again. And then if appropriate, the patient is compensated and there's an apology. And then ideally, lessons learned will be shared. So this is a way to, it's a departure from the deny and defend or blame and shame approach, and ultimately will lead to, at least theoretically, a learning culture rather than a punishment culture. So at this time, the commission issued a policy or guidance document that describes its support for this approach. It said that the commission supports just culture. It said that the commission supports the adoption and implementation of CRPs across the state, and it stressed the importance of sharing lessons learned. The commission then had a number of meetings with the University of Washington and the foundation to see how the commission could support this work, or if the commission had any role in this at all. The commission was very supportive of the idea, but was concerned about a possible lack of consistency about the implementation and running of CRP programs in individual institutions. So we had a number of meetings, and an interesting idea arose out of those meetings, and that was the creation of an event review board. So this would be a board within the foundation that would be neutral and independent board made up of people from across the healthcare spectrum that would review CRP cases. So when a hospital had an event and they did their CRP, they could, if they wanted to, submit their CRP materials to the event review board, who would review those materials and then give feedback on how well they conducted their CRP. Tell them what they did well and what they could improve upon, and thereby achieving some kind of statewide consistency on the implementation of CRPs. If every box was checked, if they did it well, then the event review board would issue a certification report. They would certify the event. And then the institution or provider who gets the certification report can then decide whether to share that with the commission. And that's how we come in. So they would only share it if we had a case. So for example, if a physician was under investigation, then that physician may want to share that certification report with the commission to show the commission what they've done to prevent it from happening again. The board, the event review board, it is part of a program, one of the programs of the Patient Safety Coalition within the Foundation for Healthcare Quality. And the event review board is made up of risk managers, hospital leaders, attorneys, and patient advocates. Patient advocates are one of the largest groups in this program. So the commission created a work group to work with the foundation to figure all this out and figure out how we can work together. And that work group is called the Reduction in Medical Errors Work Group, or ROME Work Group. Earlier this year, maybe it was last year, the work group changed its name to the High Reliability Organization Work Group. And that was done to expand the scope of the work group beyond just helping to reduce medical error. So the work group, ROME committee, met with the foundation and developed the document before you, the Statement of Understanding. They did this in 2013. We attended a number of stakeholder meetings to talk about this, and we learned that stakeholders were a little bit concerned about exactly what the commission would do when a case was certified. So the commission describes this in the SOU, what the commission will do with a certified case. As I said, this was adopted in 2013. It was revised in 2015 and 2017. And a new revision is before you now. And it details the procedure. So Amelia's on that page. It's section 4. This is the commission protocol. And the protocol provides what the commission will do with the case. So A says, when the commission receives a complaint about substandard care or mandatory report, the commission will use its normal process and inform the complainant it has received the report. B says that if the provider is participating in a CRP in their institution, or if the case has been submitted for certification to the event review board, if the physician tells us that this is happening, then we'll record it in the file. C says we will always be consistent with our statutory mandate to protect the public and evaluate the case according to our normal protocols. And then D provides that if we receive a certification report, then we'll place the report and any other information the hospital wants to give us, accompanying materials, we'll place it in the file. And then the commission, when it reviews the case, will review its own investigation and the certification report and the accompanying materials and use its discretion to determine whether to close the case with no further action based on remedial action that has been completed and its judgment that the patient safety issues have been addressed. And then D says, anything we receive is subject to public disclosure except for the certification report and any accompanying material that is part of a CQIP, a Coordinated Quality Improvement Program. So the reason we got specific in Part D is that there were questions raised at stakeholder meetings that said, how do we know the commission is going to, when they get the report, that they're going to even read it or even consider it? So we put in the SOU that we will put it in the file. Anything the hospital wants to give us, we'll put in the file, and it will be considered along with the commission's own investigation. So big question on this is the commission treating these cases that have been certified differently from other cases? And the answer is essentially no. If you read that and the procedure I just went over, it's really not treating these any differently. We're just saying we'll consider the certification report in our analysis. So this doesn't change the commission's processes. It doesn't affect the commission's authority or discretion. The event review board got up and running in 2017, and it received between 2017 and 2020, I think it received 20-something cases. We really thought, or I thought, that many, many more cases would be submitted, that this was a very good program to improve processes within hospitals and improve patient safety. They got about 20-something cases. Only 6 of those were sent on to the commission. So then the pandemic hit in early 2020 and hospitals had higher priorities. They stopped submitting cases and the event review board stopped meeting. This summer, with the waning of the pandemic, the foundation got additional money from the legislature, and they hired a manager to run the certification program and the event review board, and promised that the event review board would start meeting again. So the HERO committee thought this is an excellent time to re-engage with the foundation, take another look at the statement of understanding, which hadn't been changed, as I said, in 6 years. So we met virtually with the new CEO of the foundation, Ginny Weir, and the head of the Patient Safety Coalition, Steve Levy. We met in June and July, had 2 meetings. By we, I mean Dr. Domino was there, Melanie and Micah were there, Jimmy Bush attended, Pam Kohlmeyer attended. I may be forgetting 1 or 2 people. And then we went over this SOU, made some changes, and I wish the changes were marked there, but they're not. But I can tell you there were no significant changes except for one. Of course, we had a name change. We changed that. We changed some wording. There was a paragraph near the end. This is the only significant change. There was a paragraph near the end that described something that we thought was a good idea back in 2013, and that was that as cases come into the commission and as this process gets more robust, and as the commission gains confidence in CRPs and institutions and the certification process, that the commission would consider placing cases on hold if they were in the certification process. Well, we didn't get enough cases to gain that confidence, so that never happened. So we took that out. The last section in that document talks about, well, it's not the last section, but talks about lessons learned. If you could scroll up just a little bit more, lessons learned. So the HERO committee talked about this, and we're going to make that a high priority to engage with whoever wants to engage with us, because we have a lot of information, and somehow create a mechanism to share lessons learned with the healthcare community. So the HERO work group submits this to you for your consideration and approval, and I'm happy to answer any questions.
Thanks, Mr. Farrell. Dr. Chung, you're chair of that work group or the committee. Do you want to make any comments?
Yeah, I just wanted to add that that this work is obviously very critical and ongoing, and as Mike stated, the relationship between the commission and the foundation is. We hope that this will strengthen that relationship as we move forward to work together to reduce the medical errors, and that we want to continue to help them clarify the role of certification for hospitals. I think because that work was paused for a few years due to lack of funding, we may have lost some traction at the institutional level. And it would be, I think we'd want to try to re-engage those stakeholders and help the foundation relaunch the certification process for them. Now, that said, I think we also need to continue to dispel the misconceptions of what the stakeholders had continuously thought our role would be. We want to clarify that the certification does not take the place of a commission investigation, and it does not automatically result in a closure of a case, but that we have pointed out that if we have the certification in place at the time of the investigation, there is a more likelihood, and this is again just giving a little bit more information though, for those of you who are new, we never agreed that having the certification in place would necessarily result in a closure of the case, but that having it in place may give a higher likelihood of closure, such as a unique closure, because most of what we would have asked for in a STID or order would have already taken place, and also recognizing the fact that a lot of these errors are not individual errors, and disciplining one person is not going to take care of the root cause. And so in that sense, conceptually, we want to be partnered with them as well. So just wanted to add that.
Thank you. I'll just say as well, a lot of medical errors, especially in our system errors, and not individual errors. There's a whole team of people and systems that are involved, and learning from error is really important. It's unfortunate medical errors happen. The way you can reduce that is to study them and learn from them in that circumstance to change your systems in environment, in your hospital environments. Now, my understanding, since Bruce Cullen, who was my former chief at Harborview many years ago, had really tried to move this along within the commission. And one of the concerns I think that also happened at the time is that it obviously an individual practitioner who's not working in a large hospital system is sort of disadvantaged in this process. And I think in order to address that, we actually in investigations of medical errors ask the individual physician or physician assistant questions that are very similar to what we would see in this certification process, such as what kind of systems were involved in this error. What have you learned from this experience? What sort of CME have you already done? How have you educated your partners in this? So I think this work, it's time to bring this back to the commission. And thanks, Ms. Farrell, for all your work, and Dr. Chung for leading this effort. Are there any other comments? Please raise your hands if you have any comments. Mr. Farrell, do we need to take a vote? It says action, or is this just, it says report / action?
Yeah, I believe you do, so that Kyle can sign it and send it on to the foundation. But if I think it'd be a good idea to vote.
So is anyone willing to recommend that we approve the document?
I recommend we approve the document as written.
Okay, do we have a second?
I second.
Okay, all in favor, please raise your hand or say aye.
Aye.
Any commissioners opposed to this? I'll let you get your hands down. So hearing no oppose and approval. So yes, you can finalize this. Thanks for all your work, Mike, on this document. All right, we will move on. Rulemaking activities. So it looks like we have a request to initiate the next step of rulemaking process for CR 102 for WAC 246-919-330 postgraduate medical training. Emergency rulemaking filed as WSR 23-15-056 on July 13th, 2023 has already been completed on the subject. This request is to make the emergency rules permanent through standard rulemaking. This rulemaking is a barrier to licensure for MDs. The CR 101 was filed on August 23rd, 2023 as WSR number 23-18-005. Who would like to, from staff, tell us a little bit about this?
That would be me. Good
Thank
morning.
you.
So again, like Dr. Domino just said, we have already completed the emergency rulemaking on this subject. We are removing a couple of barriers to licensure with this rulemaking. That emergency rulemaking is already in place, so we are just moving along with the standard rulemaking to make that emergency rulemaking permanent. And so if you have any questions about that, you can let me know.
So any questions? Ms. Boyd, do we just, we need to take action on this, so we want to have, if there are no questions, have someone make a motion for initiating the next step in rulemaking?
Correct.
Anyone want to make this motion?
So moved.
Okay, do we have a second?
Second.
Any discussion of this at all? I don't think so. We had a discussion at the rulemaking. All right, all in favor, raise your hand or say aye.
Aye.
Okay. Any commissioners opposed to initiating the next step in rulemaking process? Okay, well, it looks like no one's opposed, all are in favor, so we can go ahead and initiate the next step in the rulemaking process.
Thank you.
All right, Ms. Boyd, we have another one. A request to initiate the next step in rulemaking process, CR 102 for physicians and physician assistants, general provisions for opioid prescribing and taping rules. The CR 101 was filed on August 16th, 2023. It's WSR number 23-17- or actually it's 094.
So
Ms.
this
Boyd,
rulemaking, yes, This rulemaking you have seen before because you approved the 101. It is to move to the next step in the rulemaking process. We had a Dr. Turman, who's a former pro tem commissioner, do a comparison between our current rules for opioid prescribing and the new CDC guidelines that came out last year. And you approved updating 3 items, and they are exempting patients with sickle cell disease, state and rule that not all chronic pain patients need to be tapered off opioids, and then create clearer rules regarding biological specimen testing. And so with that, we have created some draft language, and so we are asking that we move to the CR 102 process with this one. Yes, Heather.
I think the commission needs to see the draft language before they can vote.
So I thought we had put it in there, but we have changed the packet so many times.
Oh, it could have been in a previous version.
Isn't that language there at the, I mean, it doesn't come through very, no.
No, this is just the 101. Hold on just a second. Okay, I'll show you the MD language. And then the PA language is substantially similar. So we're adding the treatment of patients with sickle cell disease in the exclusion section, and then just renumbering the exclusion section. And then we're removing a reference to biological testing in the periodic review of chronic pain. And then we're adding this information about biological specimen testing. And it says that biological specimen testing should not be used in a punitive manner, but should be used in the context of other clinical information to inform and improve patient care. Physicians should not dismiss patients from care on the basis of a biological specimen test result alone, as this may lead to adverse consequences for patient safety. And that is language that's very similar to what is already in the new CDC guideline.
Okay, do we have any questions about this or any discussion about the changes?
And then,
We've
sorry,
already had, oh, sorry, one more?
There's one more. And then we added this sentence or a couple of sentences to the tapering considerations that not all chronic pain patients will need their opioid prescriptions tapered, and relying on medical decision-making and patient-centered treatment, the physician shall consider tapering or referral for a substance use disorder evaluation when. So everything that's not in red is not changed. We just added that first sentence and then add a little bit more to the second sentence.
Any comments from any of the commissioners, Dr. Chung?
Yeah, going back to the added language above, I might question the need for the last portion of that sentence where starting from as this may lead to adverse consequences for patient safety. I'm not certain if that phrase is necessary and could lead to a point of argument. I think it would be stronger and less restrictive for us to just say physicians should not dismiss patients on basis of a biological specimen test result alone, period. I don't think that is a statement that requires qualification with adverse consequences.
Thank you. And any commissioners have any comment? That seems very reasonable to me, myself.
I'd like to support that as well.
I'm sorry. Go ahead, Ed.
Sorry, I just wanted to echo that I would like to support that comment as well.
Yeah, I agree. You're right. I agree that really is not necessary.
And any commissioners feel that the comment is necessary? Nope. Okay. So, Ms. Boyd, with that change, should we take a motion to accept whatever it is? Sorry.
So I think
Yeah.
you have to make a motion to approve the change to the language, and
Okay.
then you can do a motion to approve
The
moving to the
rulemaking.
CR 102 process with this revised language.
Okay. Do I have a motion to approve the change in language that Dr. Chung suggested and that appears on your screen?
Dr. Domino, I think you can take my suggestion as the motion. So all you need is a second.
All right. And we already had a second?
Yeah.
Okay, great. So all in favor of approving the change that Dr. Chung suggested since that phrase was unnecessary, please raise your hand or say aye.
Aye.
Any commissioners opposed to this? We'll just wait a minute to get the hands off. Hearing none, we approve that change in the document. And then the next step is to request to initiate the next step in rulemaking process for CR 102 for physicians and physician assistant general provisions for opiate prescribing and tapering rules. And this CR 101 was filed on August 16th, 2023. So do I have a motion for taking the next step in rulemaking from someone in the commission?
I so
See
moved.
everyone. Yep. Okay. We have Dr. Murphy and then Dr. Chung seconded it. Any further discussion of that? Hearing none, all in favor of initiating the next step in rulemaking, please raise your hand or say aye.
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 Okay. Any commissioners opposed to initiating the next step in rulemaking? Hearing none, can go ahead and initiate the next step in rulemaking process.
Thank you.
Thank
everyone.
you, everyone. All right, we'll move on. List and labels request.
So this is Heather. I can give you my recommendations on these requests. The first is recruiting resources. And I don't, doesn't appear that they meet the definition of either a professional association or educational organization. So for this one, I would recommend denying. The second is the Washington State Medical Association, and they are a professional association, so I recommend approval.
So do we need to take these each separately? I assume so.
I think so.
Okay, so do I have a motion for denying the recruiting resources requests for lists and labels or approving?
Motion.
Okay, do we have a second?
Second.
Okay, all those commissioners in favor of denying the recruiting resources list and labels requests, please raise your hand or say aye.
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 Any
Aye.
commissioners opposed to this? Please raise your hand or say aye. Hearing none, we will vote to deny the recruiting resources requests for list and label. Okay, do I have a motion to accept the Washington State Medical Association's request for lists and labels? Dr. Murphy, we have a second. I don't necessarily see everyone, so
Second.
Okay, Ms. Blake, second. Then all in favor of this, please raise your hand or say aye.
Aye.
Or-
Aye.
Aye.
Okay. Anyone opposed to the request of the Washington, approving the request of the Washington State Medical Association? Hearing none. We've approved the request of the Washington State Medical Association for the lists and labels. All right, the next step, delegation of signature authority. Mr. Matthews.
Good morning again, commissioners. So this is a procedure that you have signature authority that you delegate to staff to take action in certain instances. It is highlighted by the area that the staff will be working in. Primarily, the changes here are in licensing to reflect some changes in statute that occurred in 2021 related to physician assistant law, as well as updating the staff who are able to do certain functions as we have had staff changes, and so that's the major update there. So asking for your approval on this.
Okay, any questions about this from the commissioners or any comments? Will someone make a motion to approve? This is a for Action Island, right? Yes. So will someone make a motion to approve the delegation of signature authority?
Motion.
Second, anyone?
Second.
All in favor of this, please say aye or raise your hand.
Aye.
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 Any commissioners opposed, please say yeah, raise your hand or say aye. Hearing no proposal. We have approved the delegation of signature authority. It's
Thank you,
requested.
commissioners.
All right, the next thing, number 7.0, is the policy committee report. Ms. Blake, public member and chair of the committee, will present the items discussed at the policy meeting held on October 13th, 2023.
Thank you, Dr. Domino. We had a couple of interpretive statements that we reviewed at this meeting. The first you can see is the application of the office-based surgery rule for the use of nitrous oxide. The committee reviewed, discussed, and following that, recommended to adopt this and move it to rulemaking. I hope everyone had a chance to take a look at this. And if there are any comments, Dr. Domino, I know that you had a lot of work put into this as well in review of this.
So I'm happy to say something, but I'd like to see if anyone on the commission has any comments about that. Or if you want to think about it a minute, I'll give you my perception of this. So let me say that we were asked by WSMA to consider use of nitrous oxide in smaller concentrations for use in offices and office-based settings. And the fact is that we heard that there are a number of other groups, the dental group, I think the naturopaths they are also allowed to use it. And there are procedures that are painful to patients, especially in some urologic surgery, that nitrous oxide can by itself, while there are some hazards to it, both for personnel in the office and for the environment, it does offer pain relief during these procedures. An example of one I can say from a colleague who I know from out of state where they do allow this was where they have a urologic procedure done in basically associated with treatment of prostate cancer, and was offered either a benzodiazepine, which doesn't offer pain relief. It was just an oral Valium basically, or nitrous oxide 50%. And the nitrous oxide did help with the pain relief during that brief procedure. It's like a 10-minute procedure. And it can be done safely. I think what we tried to draft is something that made it what I think is safe for patients in the office who might be used. And the document, Mr. Farrell did a great job in incorporating some of the items that were from the office-based procedure, ambulatory, things. I think the biggest concern is that many of these small offices didn't want to follow a lot of their rules, and because they, in particular, the cost of the certifications and that. And what we did is we felt that the amount of nitrous oxide was limited to 50%, which there are devices available with that. We included things such as monitoring the patient during this, which you would do under anesthesia care, and having a separate provider there who is trained, as well as the doctor or physician or PA who's trained in this regard about that. And in addition to having safe storage of the nitrous oxide, since there is a risk of abuse, it's a drug of abuse as well. And we said that there would be no other sedatives used, oral sedatives or anything else. It's simply nitrous oxide, which I think can be safe. Nitrous oxide has been used a lot in labor and delivery for pain relief in these patients. These urology patients who people are thinking of this are a different kind of a patient in that they're often older and sicker, but 50% nitrous oxide where they're breathing spontaneously, someone's monitoring them, where there are exclusions that are there of contraindications to use of nitrous oxide, such as someone has a pneumothorax, that nitrous readily diffuses into air-contained spaces, or say someone recently had cataract surgery. Those kind of things in the training, I think we built these safeguards in. And so I believe it allows flexibility and can be done safely. And obviously the individuals who would wish to use this would need training, significant training, and need to follow these rules. Any comments about that? Mr. Farrell, you worked hard on this.
Yeah, good morning. I don't have any comments.
Any commissioners have any questions about it? Okay.
We have a hand up, Dr. Domino.
Can I ask a quick question?
Oh, sure. I can't see everyone. Yes.
I know, I'm on telephone. This is Dr. Curry. Sorry, quick question on the training that you mentioned, Dr. Domino. There's no, I assume later on in rulemaking or something, we define how many hours or what type of training. Is that right?
Yeah, I mean, there is training available, like dentists have training, people in the hospital. I mean, I don't know if we need to specify that. I mean, even to get the equipment, you have to be trained.
Right. I just remember for like conscious sedation, when you're the only doctor in the room, you have to have quite a bit of training and like requirements testing even.
Well, you have
sure
to
you know
have,
what
I
to
mean,
do.
what we did right into this, I mean, I think you need to have someone be ACLS certified in this and other things. I don't know what, I mean, you need to be trained in the use of the device. How many hours, I can't say.
Okay, thanks. I was just wondering. Appreciate
Yeah, I
it.
mean, there is training. Mr. Farrell,
I think we can address that during the rulemaking process.
Right. Sounds good. Thanks.
yeah, I mean, right now it's just what? an interpretive
Statement,
Yeah.
moving to rulemaking, yes.
Yeah, I mean, I think that kind of thing would have to be sorted out. Mr. Lopez, you had your hand up.
Yes, thank you. Thank you for the hard work on this important document. I had the same question as Dr. Curry did. Thank you for answering that. The other question I had was, is there something significant from a therapeutic or modality that 50% is the magic number of concentration?
Okay, well, that really ended dealing with patient safety. And a lot of the devices do limit it to that. It really 70% nitrous oxide, which, well, we don't use nitrous oxide in my hospital. It's gone. And the reason why it is because of it's a greenhouse gas, and people are really worried about the environment in that. It does, most nitrous oxide is actually produced by farming in animals. So it ends up being a greenhouse gas. And we have alternatives. We have lots of drugs and newer agents. When I trained, nitrous was really popular, and nowadays there are other agents to use. So I think the 70% is there are people who will be anesthetized. We don't want someone to be anesthetized. We want someone to be sort of drugged temporarily, but awake, able to maintain their airway and to be safe and to breathe adequately. So that's why that was chosen. Particularly older patients, and again, you have that issue, they would be more sensitive. They can be anesthetized at lower concentrations. Oftentimes with anesthesia, we add many other drugs. So this is why we wouldn't allow them to have, say, nasal midazolam, intranasal midazolam, which also can anesthetize those patients. So that's why that was picked.
All right, thank you.
Karen, if I could just say 50% is generally considered the safest concentration. And so it comes that way for use in emergency departments. And I actually supervised 14 different
stuff, yeah.
EMS units that had it, where the patient would hold it to the mask to their face, and if they were anesthetized, the mask would fall to the wayside. And so it was safe. They were still able to protect their airways, and 50% was considered, ubiquitous as the safe number concentration.
Thank you very much.
Yeah, and lower concentrations may not work very well. The one thing is you do get what we call diffusion hypoxia that can happen. And so ideally in these office settings where you have someone monitoring the patient, you don't want to just take the mask off at the end of the time of its use. You need to give 100% oxygen to wash that out. Otherwise, what happens is the nitrous will quickly go in the lungs, and if you're on 21% oxygen, you can develop a hypoxic mixture. Again, not a worry in a young person, but in the an older person.
COPD here.
Yeah. So any other questions or comments? Okay. Miss, do you want to take both of these things, Miss Blake, together?
I think we have to take them separately, if I understand correctly, Amelia.
So we have to do, on this particular item, you would have to do two
Yeah.
votes. You would have to vote on approving the interpretive statement and then vote on initiating rulemaking on this subject. You'd have to do two different ones.
Okay. Can I have a motion for approving the interpretive statement? Again, I can't see everyone. So Dr. Murphy, second?
Second.
Great. So all in favor of approving the interpretive statement?
Aye.
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 And anyone opposed? Okay, so the next thing is again, it's to begin rulemaking. Is that what you said, Ms. Boyd?
Yeah.
Correct.
Yes, we're, yeah.
Proposed to begin rulemaking on the application of the office-based surgery rule to use of nitrous oxide. Can I have a motion for doing that?
So move.
Okay, and a second?
Second.
Anyone? Okay, several seconds. Okay, all in favor, say aye. Raise your hand.
Aye.
Aye.
Anyone opposed to this? Okay, we approve the interpretive statement and we will initiate rulemaking. I'm sure a lot of these safety issues and specifics will be sorted out in that process. Okay, the next proposal is to begin rulemaking to define a qualified physician under the new optometry law called Enrolled Substitute Senate Bill 5389, Chapter 400, Laws of 2023.
Thank you, Dr.
Ms. Blake?
Domino. Thank you, Dr. Domino. This was discussed and it was felt that rulemaking would be best. And you see the memo in front of you as to why we've determined to go to rulemaking. Also, the Board of Optometry is going towards rulemaking. Are there any questions or concerns with regard to this document?
And the policy committee did vote to approve rulemaking.
Rulemaking, yes. Felt rulemaking would be best rather than an interpretive statement. And the Board of Optometry is going that way as well.
Okay, does the policy committee serve as a proposed vote, or do we need a commissioner to put this up for vote?
If it's going towards rulemaking, Amelia, Mike, Mr. Farrell, do we need a vote from the commission members?
So the committee recommendation serves as the motion, and then
Thank
you just
you.
need a second and approval. Yeah.
Thank you.
Do I have a second for this? Someone, I can't see everyone. Someone accept. Okay. All in favor of beginning rulemaking process on this definition of qualified physician under the new optometry law, please raise your hand or say aye.
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 Anyone opposed?
Aye.
Okay, hearing no opposals.
No, that concludes this report, unless Mr. Farrell, you had something else that you also wanted to add.
Nothing else. Thank you.
Thanks, Ms.
Thank you.
Blake.
Thank you.
All right, member reports. Does anyone have a member report? Can't see everyone, so if you do have one, please speak up. Okay, I don't see anyone of the commissioners having a member report. Staff member reports. Any further reports from staff? Mr. Kiernan.
Thanks, Dr. Domino. I wanted to do two things. The first of which was to highlight the fact that both Dr. Yu and Dr. Curtis Dr. Curtis is about to term off the commission, and Dr. Yu's replacement was appointed, so her time with the commission has come to a close. I did put a couple sentiments in there, and I hope you'll take a moment to review those. I very much appreciated working with both Dr. Yu and Dr. Curtis, albeit obviously in different capacities, but they were both incredibly reliable participants in commission business. And Dr. Curtis in particular was a favorite of the legal staff. She just did wonderful work with us as a pro tem, and she will be sorely missed. The other addition is with regard to the commission meeting schedule. Currently, we have disposition meetings, a virtual one scheduled for January 11th, along with virtual personal appearances. And then we have a in-person disposition only session scheduled for February 15th. And then just 3 weeks later, we have another in-person disposition and personal appearance session scheduled for March 7th. These are not business meetings, so we don't necessarily need your approval, but based on current caseloads and investigation, I'm going to go ahead and cancel the February 15th meeting. Oh, thank you. I don't know if that's Amelia or Fatima at the controls, but thank you. So you'll see that February 15th one. We're going to go ahead and cancel that. Current caseloads dictate that we're very unlikely to need all 3 of those right in a row within a kind of condensed time frame. So that is just a heads up. I'll send out an email after the meeting just as a reference, so you can remove that from your own schedules as well as any travel schedules that you have. And again, I thank everybody for their kind of continued flexibility as we kind of work through this new meeting system. I think staff is certainly still getting used to it. But like I said, we saw an opportunity to remove that from your time commitment to commission work. So we're going to go ahead and do that. So the February 15th session in person, which was scheduled, I think it was likely to be down here in Tumwater, is going to be canceled. I will send out a confirming email. That's all I have, Dr. Domino. Thank you.
Great. Thank you for letting us know. All right. Any other staff have anything they'd like to bring up? All right, Ms. Carter, AAG, can you give us a report?
I just have some information I wanted to provide to the commission about litigation holds. Mike Hively let me know that you guys have been getting quite a few of these lately, and people aren't exactly sure what they need to do. So I was just going to sort of explain what they are and quickly tell you what you need to do. So from time to time, the commission does get sued. A lot of times it's a tort action from a disciplined physician, but you will receive, if there's a lawsuit or if we anticipate one might be filed, something called a litigation hold, and it comes in the form of a letter to you, and it's basically anytime there's litigation, we need to preserve any potential evidence from that case that you might have in your possession. So what you need to do is go through, read it. It's usually going to be about a physician. Search your records. If you have anything about the physician, just segregate. So say it's emails, if you can put all that stuff in one file, and make sure and turn off any automatic deletes. Sometimes we have files that delete automatically after a certain amount of time. If you can turn that auto delete off, and then just let Mike Hively, I think it's Mike, correct me if I'm wrong, but let him know whether or not you have records. You don't need to produce them right away. You just need to let staff know whether or not you have records, and just make sure those aren't deleted. So don't worry when you get one. It's just a way of everyone being on notice that there is some litigation and that we just need to not delete and preserve records. If you are named personally, and this has happened recently, I will be in contact with you about requests for defense from the AG's office. But these litigation holds do not mean you're being sued personally. It's usually just the commission as a whole, and we just need to preserve records. So I'm happy to answer any questions now, or if you have questions later, you can always send me an email or give me a call too. All right, thank you.
Great. Well,
Dr.
10.
Domino, I have I just have a couple of things.
Okay.
I just want to thank Mike for all of his work and congratulate him on becoming the supervising attorney in the legal unit, and I'll be sad to see him go on policy committee, but happy that he'll stay till we find a replacement. So thank you very much, Mr. Farrell, for everything. And also, it looks like that it looks like it was a great offsite team building picnic that the team had with the Department of Health and Oils, Nursing, and Attorney General's office. So I didn't realize that that collaboration goes on. So I just want to say that sounds like it was probably a good time. And that's all I wanted to say.
Great. Does anyone else have anything else they'd like to say before we conclude this meeting? Don't see anyone raising their hand. So with that, we'll adjourn the business meeting. And thanks for joining in. Thanks, staff, for all your hard work. Bye, everyone.
Have a good weekend. Bye.
Bye.